presentation. And now I invite Dr. Sudha V, Professor and Head of the Department, Government Medical College, Thrissur, to speak about the interpretation of OCT and FFA, key points everyone should know.
So thank you, Dr. Manju and the entire Ernakulam team for giving me this opportunity. This is a very practical topic. You should know what OCT and what FFA you're going to do before you start upon any program. So first thing first, OCT should not replace a detailed fundus examination. It is not at all a replacement. Always look at the OCT picture as well as the fundus photo to give you a hint. Some things which you should know, there is an international classification now. There is something called layers, there's something called band. Now what is a layer and what is a band? Layer is an anatomical structure. So like if you have an internal limiting membrane, that is a layer. But the band is what you see on OCT. The layer and the edge. You are seeing that edge, that is the band. So layer is an anatomical structure. Now the things which do not have an anatomical layer, that is called a zone. So clear? So band, layer and zone. So you have a hyperreflective, that all you already know. Next is which color do you choose in an OCT? So do you like the false color? That is a very beautiful color. It's got all sorts of colors. But the problem with the false color is contrast is not too good. Second, the red doesn't mean that it is a very hyper-reflective structure. It's just a color. It's just a false color. So green is not really suggesting that there is a hyper-reflective or it's not a staged set. So while the gray scale, the more white it is, the more hyper-reflective it is. So it is telling you something about the reflectivity. So for example, if you see this picture, you see the upper one, you are giving a beautiful, the outer layers, you are seeing all the two lines. But in the lower one, you are just seeing the red color. So the contrast is much better with the false. And if you see the epiretinal membrane on the first slide here, on the left side, you can also see the curves of the retina under it. So it's well seen. Now there are many scanning protocols which are available. Which one would you choose? That is important for you. These are all different protocols. What do you want to choose? So there are also a lot of printouts. Now which ones? These give you a lot of information. You just need to know what you have to do. So what are we going to assess? We need to assess the retinal thickness. We need to assess the morphology. We need to assess the map. How thick, where and what, right? We also need to know if there is some traction, and we need to know the outer layer integrity. So one line scan. What is a line scan? A lot of A scans are going into the tissue in one line. Right? So that number of A scans is giving you 1 B scans, right? And number of B scans is giving you a raster line scan. So what is it doing? It's just sending A scans in one particular line. So what will this give you? This will let you interpret that. B scan will let you interpret it layer by layer, the entire layer from the outer retina to the inner retina. So the changes which you can see in diabetic retinopathies on a B scan is traction. You can see drill. That is disorganization of the inner layers, and you can see cystoid spaces. So that is clear with the B scan. Now what is volume scan? So you see the next one. This is a cube. Can you see that painting, this color here, this thing? I'm sorry, I don't have a pointer. The first thing which is just showing you a square. It's not a square, it's a cube. What it means is there are lots of lines going in this 6 millimeter cube, both horizontally and inside it and vertically. So it is a cube or a 3D space which these lines are going and they are scanning for you. So it is color coded because it is supposed to show you at a picture the topography. So where it is high, where it is low, right? So the macular cube scan which is coming on the Zeiss machine, that gives you 128 into 512, which means that there are 128 B scans. But the B scan, each of them has 512 A scans. So right? So that is, so the more denser you go, the B scans increase, but the A scans are reducing. So the space is decreasing, but your resolution is reducing. Is that clear? So that is what you should take. Now, so after that, once the cube has been taken, it cuts through that cube and gives you a 2D picture of your layer thickness at each level. So that is your topographical or the thickness map which you are getting, which the ETDRS grid will tell you the central thickness. I hope you understood this. This is just a cube, and out of this various levels are giving you that scan. So why is that? That is a raster scan. Those are line scans. But there are also something called radial scans. Now, why do you need a radial scan? Suppose you're looking at the fovea at one single point. You would like to see it from all directions, right? So that radial scan is important for the central point, for the fovea. So if you can see that picture here, the raster scan below has missed that little bit of cyst. But it is seen in the fovea because all directions have been assessed here. Right, so that is the importance. So you can get other things like serial printouts, and that is for OCT. So you just need to know how dense you want to go. The more denser you're going, your resolution is reducing. So don't go in for a general dense. Generally, you can do a raster, both vertical and horizontal. But if you want detailed pictures of the fovea, you would like to go in for a radial scan. And printouts for regular follow-ups. Now, when to use an FFA? Now, because of the OCT, our FFA indications have reduced. So, mainly it is now just before laser treatment for DME. But also many people use it as a documentation, right? So, that is there. The other conditions I'll be telling you, unexplained poor visions, I'll just show you the pictures. So, thing you should know about FFA, the main camera which we are using is just the posterior pole, that is up to vascular arcades. If you want to go wide field, you can go beyond that up to the vortex veil. So these are the FFA phases. This is in the first minute up to the last phase. So usually we take an FFA initially 1 minute rapid fire, and then up to 8 minutes you can take a slow picture, and you put these pictures together. So the first one is the color photo. The first picture is the early picture. The second picture is approximately a 3-minute picture, and the last picture is around a 10 minutes picture. So what is it telling you? The changes, subtle changes which are occurring along the time. So this one is neovascularization. The first picture is just showing you subtle changes, and it becomes much more active in the late stage. About DME, we need the early picture for treatment. So you see in this color photo, you cannot identify any microaneurysm. Where are you going to treat? So you need an early picture, but that must be an early picture because the late picture will not show you any microaneurysms. So this also, the late picture is important. Sorry, can I go just a little bit more? The late picture, yeah. Okay, thank you. The late picture has, if you can see, that is only used to identify whether this is cystoid macular edema of cataract surgery, post-cataract, or of a DME. How do you identify that? See the disc. See, the disc is shining in the second picture, which is telling you that this is not DME, but cystoid macular edema, right? Irving-Gass syndrome. Also, in the mid procedure, you can take peripheral images, which you should, because there also you can identify the blooming picture hyperfluorescence which is occurring. That is the NVE which is occurring. Now, sometimes when you cannot see anything in the fundus picture, this is not a very good quality, but still you are not able to see anything. But as you take those 4 pictures, you can see the beautiful NVE and NVI, which is NVE and NVD, which is coming up. Exactly, if you want to see unexplained visual loss, vision is just 6/60. The fundus looks perfect except that 1 or 2 hard exudates are there. Here, if you take that early picture, you are going to see the foveal network. So the foveal network needs an irregularity is seen in that. It's not the oval foveal network which you're seeing. So that irregularity also comes in the early picture. Of course, in this kind of a thing, when you can't see anything in the fundus photo, you can see it all through the FFA. Beautifully it gives you. So thank you. A good image is an art. You have to learn how to take a good image, but much, much more important is your interpretation and how to use it. Thank you so much.
Thank you, Dr. Sudha, for that wonderful talk on how to interpret an OCT and FFA. I think all of us must have benefited from this very basic class on how to interpret this OCT pictures and FFA pictures.